Hello and welcome to those of you joining. We're going to let the group fill and we'll start in just a moment. Excellent. All right. I think we'll get started. Welcome to everybody joining us. Looking forward to our webinar today. We are going to be talking about practical strategies for using hybrid applicators. They're going to be drawing from our own experience here at MD Anderson. So this is our team here that works together doing brachytherapy for GYN patients. And I will start out by introducing our team, and then I'll give a few little updates from the ABS, and then we'll launch into our webinar. So you see our team here. So I am GYN radiation oncologist. Work closely with Dr. Aradhana Venkatesan, who's a diagnostic imager, MR specialist. And we are constantly peppering her with questions about our patients, about our implants. She's been a wonderful collaborator on our protocol doing MR guided brachytherapy, and we're very much excited to hear her advice and input on MR guided brachy for hybrid applicators. Dr. Lilie Lin, my wonderful colleague, GYN radiation oncologist, who is going to be presenting the cases today and talking about her own input and pointers on doing these implants. Dr. Sam Simiele, who's a medical physicist and has been doing our clinical implants and doing research on hybrid applicators and brachytherapy for cervical cancer. And then Dr. Christine Starks, our dosimetry colleague, who has been doing our hybrid applicators from the beginning when we started doing our brachytherapy program and has just been helping make it happen all the way through. So, and she has going to do some hands-on virtual demonstrating here. So with that introduction, I will give a few things from the ABS. So we have a couple of really great virtual and in-person programs coming up. So there's a symposium coming up on building an HDR program from a big city to a small town. It is called The Tale of Two Cities. It is going to be in February, led by Eric Horowitz, who's a past president of the ABS and a chair of radiation oncology at the Fox Chase Cancer Center. And he'll be presenting with two former Fox Chase residents who built their own brachytherapy programs. There is going to be a GYN school in February. So, you know, the ABS has had a long tradition of having a wonderful GYN school. This year, it is going to be a virtual school with a lot of the same content that has been covered in person over the last few years, but with the additions of new developments and making it virtual so everybody can join us regardless of any travel restrictions. And then ABS has partnered with the Grand Rounds of Urology to have a new course in prostate brachytherapy. This lecture series has 30 different lectures, which are part of this program. And then we are very excited about our annual meeting. That will be in person. That's going to be in June in Denver. And so those meetings are just a few of the exciting things that ABS has going on. So with that background, we will launch into our presentation. And so I will hand it over to Dr. Lilie Lin to start us off.
Great. Thank you, Dr. Klopp. So our learning objectives for the hour are to review patient selection for hybrid applicator systems, to discuss practical strategies for brachytherapy planning, and discuss incorporation of MR imaging for hybrid applicators. Next. Okay. So I'll just start out with a clinical vignette here. So this is a 43-year-old woman that we treated about 2 years ago who had a history of irregular menstrual cycles for about 6 to 12 months with progressive pain and increased vaginal bleeding. On pelvic examination, she had a 6-centimeter mass completely replacing her cervix with extension to the upper third of the vagina posteriorly with bilateral parametrial involvement. And her biopsy was consistent with squamous cell carcinoma. So this is her initial workup imaging. So it included a pelvic MRI as well as a FDG PET scan. As you can see on the T2 weighted axial and sagittal images. She had a very large 6.5 by 6.5 centimeter mass replacing her cervix, involving the lower 1/3 of the uterus as well as the upper third of the vagina posteriorly, as you can see on the sagittal image. There was also infiltration posteriorly through the mesorectal fascia without frank invasion into the rectum, as well as parametrial involvement. On FDG PET, I'll just point out that she did have multiple pelvic lymph nodes, the highest being a 1.5 centimeter left common iliac node. So she was dispositioned, next slide, to cisplatin and radiation. I just wanted to show her external beam radiation plan. It's fairly standard here. We gave 50 gray to the GTV and a simultaneous integrated boost with 45 gray to her nodal CTV as well as her central pelvic cervical mass. She then received a sequential boost to lymph nodes to a total dose of about 60 to 64 gray, inclusive of the brachytherapy dose as well. So we really wanted to focus today on her brachytherapy treatment. You can advance to the next slide. Okay. So our algorithm at Anderson is to obtain a mid-treatment pre-brachy MRI scan. Typically, this is done around fraction 20 to 24, depending on when we plan to do the first implant. We use both pulse dose rate brachytherapy as well as high dose rate brachytherapy. But as you can see here, she still had a fairly large residual mass, about 4.5 by 4.5 centimeters. And there was still involvement of the right parametria laterally, as well as some involvement of the mesorectum or mesorectal fascia. Next slide. So for her first implant, we did a PDR implant using a standard Fletcher suit, Tandem and Ovoid applicator system using CT for planning. And in red, you can see is her high-risk CTV that's contoured. And if you can see here as well on the right parametrial side laterally, there was some underdosage, and I won't go into the nuances of her treatment as Dr. Simiele will discuss that later on. But suffice it to say, we were concerned about the dose, whether we were adequately dosing the tumor laterally along the right parametria. So for her next implant, we did plan a hybrid interstitial application. So you can advance to the next slide. So this just kind of opens the question or begs the question of how do we select which patients are ideal for a hybrid applicator system? So typically we might think of patients that have very large, bulky disease, but also patients that might have more eccentric disease, right greater than left disease, or more extensive parametrial disease laterally, like in this particular patient. I just coalesced her images onto this one slide. Next slide. And this is a second patient where we'll show her treatment plan a little bit later, but this patient has very eccentric disease, more posterior than anterior disease. On the left-hand panel, you can see these are T2 weighted sagittal and axial images showing her disease centered around the posterior lip of her cervix. And the pre-brachy MRI scan, you can see that she's had regression of her tumor, but still in the anterior posterior direction, it's probably a little bit greater than 2.5 centimeters. So in order to treat that disease adequately with just a standard tandem and ovoid or tandem and ring applicator system, it may have resulted in a high dose to the anterior bladder in order to treat that disease adequately. Next slide. So at Anderson, we have a couple of different options in terms of what to use for our brachytherapy. So in the main OR, we have ultrasound capabilities, KV imaging, and more recently, we do have in-room CT capabilities, although we do have to compete with other surgeons for that resource. And then in our outpatient building, we have a brachytherapy OR suite, which is on a CT simulator. We also have ultrasound capabilities, and radiologists will come down and help us with that. And then we have in our main buildings an MR brachytherapy operative suite as well, and I'll show you images of those. How to think about which patients to target for each of these workflows. We certainly take into account, most importantly, the patient's tumor and their anatomy, maybe also their comorbidities, in patient anesthesia preference, as well as patient preference, if they can have both HDR or PDR. And then certainly if we need to place needles, we'd like to use an MR Brachy suite if it's open. Next slide. So I just have a couple of slides of our facility. So this is our HDR brachytherapy facility. So on the left-hand panel, left-hand image is the HDR treatment vault. It's a fairly standard variant acuity unit in that room. And then in the middle picture, we have our CT brachytherapy operating room or suite. The applicators are placed in between the table, CT-SIM table, and the scanner. So there's not a lot of room there. And then the third picture there just shows our post-operative area, which is just outside of our CT simulator. Next slide. Oh, so you'll see in the panel on the left is our anesthesiologist putting the patient to sleep. And in general, we can use moderate anesthesia in that room. And then on the right-hand image here, you see, I think one of my partners, Dr. Joyner, and one of our residents putting the applicator in. And again, it's a very tight space in between the table and the scanner. And we scan these patients' feet first. And we scan them while they're still under anesthesia. That way, if we do have to make any adjustments, it's fairly straightforward to put their legs back into stirrups and do any adjustments and then rescan them. And we do wake them up in between the placement of the applicators and their actual treatment. And so these images of our MR-OR brachytherapy suite, this was retrofitted to allow for anesthesia capabilities. This is a 3T MRI scanner, and the color change here from the light brown to the darker brown denotes the 5 Gauss line. We place the applicators in the brown region. You can see the table here, which is what we use. So again, it's ergonomically, it's not as ideal as it would be in a main OR or general OR situation. But we do use MRI safe equipment, as well as we modified stirrups that are MRI safe as well. Next slide. And yeah, this is just a picture of our equipment and our system, the MR safe stirrups. Next slide. Okay. So we'll focus today on the Elekta Venezia applicator system, which is what we've used for the following patients. I just wanted to switch it over to Christine Starks, who is one of our dosimetrists who will guide us through some of the practical aspects of the system and planning.
Before we transition to Lilie, I want to ask you just a couple of questions that I think we talk about a lot, but I feel like a lot of this has been driven by the EMBRACE data and showing the dose response and the normal tissue data and the importance of meeting those constraints. So can you just say, along the patient selection decision tree, what are the thresholds for you that would make you want to do a Venezia or a hybrid applicator for somebody with cervix cancer based on their doses?
So, in our experience, I think we've often done, say, like the first implant with a standard applicator system to see, whether it's HDR or a pulse dose rate applicator system, to see kind of where the dose distribution is and where maybe a Venezia or a hybrid applicator system could really benefit our patients. But even I think before that, in the pre-brachy imaging, we can kind of get a sense of which patients might benefit. Now, sometimes we're wrong. Some patients that have, 10 centimeters tumors respond really well to chemoradiation. I'm sure all of us who've treated a lot of these patients have seen that. And so we're not great at predicting which patients might need applicator systems. And so that's, hybrid applicator systems. So that's sometimes why it might be useful to just do maybe the first applicator or first brachy implant with a standard TNO, but that's kind of how we've thought about it.
Yep. Okay, great. And then one last question before we go to some of the details of the applicator. I know we've done these with ultrasound guidance and with CT guidance and with MR guidance. I know a lot of those things depend on other factors that are sometimes out of our control, but what are your feelings about choosing image guidance with a hybrid applicator?
Well, so it's an interesting question. So those two patients that I showed their MR images earlier, the first one, we did we did the placement in the MR OR suite, and the second one, if you recall, the patient had more eccentric disease. Most of the disease was in the posterior cervix. We were able to do without the benefit of the MRI guidance. We did it in the main OR, and then we scanned her later on after the placement of the needles. And so if we need to use needles that are more oblique rather than parallel, and I think Christine will go through some of those nuances, it's it's ideal to use it where you do have some intraoperative guidance, whether that's CT or MRI. That's, very helpful. I think I would be more reluctant to place those oblique needles with just ultrasound guidance in the suite.
Great, thanks so much. All right, so Christine, take it away.
All right. So one of the advantages that we've found of using, so there's two different sizes. I'll start off by saying the first one is the 22 millimeter. And then that is the distance from where from source to source. And then our other option is the 26 millimeter, which again, that's 26 millimeters from source to source. Here at Anderson, we mainly use the 22 millimeter. We found that here, looking at this slide, from where the center of the tandem is out to the needle channels, the distance is only 1.3 centimeters rather than 1.7 with the 26 millimeter lunar ovoid. And we found that this distance is optimal for providing a homogeneous dose distribution between the needles and the tandem. And these positions are going to be the parallel needles that are going to run parallel with the 30-degree tandem. There are oblique needle options as well. So with the 22 millimeter, we have 3 channels for parallel needles, and there's also 3 channels for the oblique needles. Now, a nuance that we found was you cannot use, there's also a vaginal cap. So you can only use parallel needles if you're going to use that vaginal cap. Next slide. All right, so I'm going to go ahead and demo the preparation of the ovoids. All right, so I think you have to stop the slideshow, or am I?
Yeah,
there we go. Am I the biggest person on the screen? Okay, so here's one of the ovoids. So you can see here are the needle or the guide tube channels. So we have 3 different options here. Place this down for a moment. So this is the guide tube. It's a plastic tube, and there's also a screw cap on the end that you can loosen and tighten. And in that is where you place the needle. So the needle is a sharp needle tip. And within that needle is a rigid obturator that's inside the lumen. Okay. So first we're going to place the guide tube. So here's the ovoid. I'm going to place the guide tube here, and it just kind of pops right into, to look at it, sorry. It pops right into this position here. And everyone always says, oh, well, it's going to come out. That's okay, because as soon as you advance the obturator and the needle through, it's going to hold it in place. Okay. So then I'm going to take the screw cap. Again, you can tighten it or loosen the screw cap. And this is how you're going to advance the needle within this guide tube. So again, just being careful when you're advancing it, because it is a sharp tip. So when we first insert, we always want to make sure that the sharp tip is on the inside of the ovoid cap while they're placing the applicator, because we don't want to lacerate the vagina. So then once you have that placed, you're going to lock this back in place. So this is what the whole system looks like if we hook it together. So here's the front. So again, you have 6 parallel holes that you can choose from if you're going to do a parallel option. All right. So there's a couple different ways that you can advance the needle. Oh, most important, we want to label the needle. So here's these little label number tags that Elekta provides, and they're really nice because you can place them right on the guide tube. And it's very important to use the number tags prior to inserting the system, because once everything's inside, you won't know which guide tube is for which needle channel. So you can either write the position on there, or you can write what catheter number you're going to choose. So that's how you snap the number tags on the end of the guide tube. And that's a very important step. You can use a sterile Sharpie. I found that a Sharpie works the best for these, otherwise they'll smudge. Another thing is to make sure that you are using these rigid obturators. If you don't, the needle can bend once it's inside the tissue. So this helps keep it rigid. And we just want to make sure that it's pushed all the way to the end. All right, so moving to advance the needle. So the first step is you just unscrew the cap. Well, first you want to decide with the physician what distance you want. And you can just either measure it with a ruler and just draw a line with your Sharpie, with your sterile Sharpie, or there's also an insertion tool, whichever you feel most comfortable using. So like Dr. Lin mentioned earlier, we can do needle guidance with ultrasound, with CT, or MRI. So once you've unlocked the screw cap, then you can advance your needle. So when you're advancing the needle, we found that the longest needle length should not exceed beyond 6 cm. And that is because this ensures we need a 3 cm distance for the connector, for the 6 French connector tubes. So we found that 6 cm is the limit as far as advancing the needle into the cervix. Once you've advanced the needle as far as you'd like to go, you'll lock the screw cap. You can, if you're getting an MRI, you can put a positive contrast marker in the lumen. If you're getting a CT, you can leave the obturator inside the lumen of the needle. But if you're getting an MRI, you need to remove this obturator completely. Otherwise, the entire system is MRI compatible.
That's great. That's really helpful to see. I think one thing I didn't appreciate in the beginning was how much harder it can be to assemble the applicator when you have a lot of guide tubes in there. So we got a little choosier about which ones to place, because you can, once the applicator's in, you can't add needles. So the first thought was, well, let's create all the options, but then it becomes quite bulky to manage, and for some patients hard to assemble. So we've gotten a little choosier and to place the needles into the ovoid that we feel confident that we're going to need. But that was a great demonstration, Christine. I think those are good tips. And the labeling is an important one, because you think that you're going to know which one's which the first time, but once they all are in there, it is not at all apparent. So important step.
I was just going to make another comment that we found it helpful to put a stitch on the cervix so that when you're pushing the needles through, there is some counter traction so that you're not pushing the cervix away when the needles are being placed.
Yep. And if you don't have a suture for some reason, to keep pressure, pushing cranially on the applicator, because if you don't, when you push the needle in, the applicator will fall back. And the stitch is the best way, but if for some reason you can't get a stitch, definite cranial pressure when you advance the needle. Awesome. And our next, one of the questions here in the chat is a perfect lead in to Dr. Venkatesan's talk about how do you decide which needles you want to use, and as a part of that, how far you want to advance them.
Great. Well, thank you so much, Anne, and everyone for joining today. I'm happy to take questions regarding the imaging, and also want to express my appreciation for the terrific collaboration that this program has provided between radiation oncology and diagnostic imaging. Some of the more gratifying things we've been able to offer from a diagnostic imaging perspective in providing real-time or near real-time MR guidance for GYN brachytherapy is not just the optimized visualization of tumor, but also specific instances where large asymmetric tumors that would not otherwise be able to be readily treated, or in patients whose mid-treatment MRI demonstrates a less than robust response, we have the opportunity to offer imaging guidance to provide an optimal implant bioradiation oncologist. From a practical perspective as well, we've observed a reduced risk for our radiation oncologists to have to return to the operating room to optimize applicator placement when the near real-time MR guidance allows them to see at the end of procedure confidently where both the endocavitary and interstitial implants are located. Here we have an example on this slide of a case that was performed with both an endocavitary and interstitial needles that you can see here in the 11, 9, and 7 o'clock position in a young patient with cervical cancer and extensive right parametrial and posterior parametrial tumor extension. Next slide, please. So what are some of the essentials to be able to perform this in your department with near real-time MRI guidance? The first is a dedicated MR protocol, and we've worked to optimize a protocol at 3 Tesla for MR-guided GYN brachytherapy. It relies on 2D sagittal and axial FRFSE sequences for visualization of both the endocavitary and interstitial implants with the highest resolution of all of our pulse sequences. We also acquire a 3D axial T2 weighted image. That's a fast spin echo T2 weighted acquisition that can also be used for dosimetric planning after completion of the implant. We run an optional coronal T2 weighted acquisition as well. That can be generated from your 3D axial acquisition, or a dedicated coronal sequence can be derived from your FRFSE sequences if that is desired. And I'll show some examples at the end of this slide segment of our index patient's case and how we leverage coronal T2 weighted imaging at the end of the procedure to see where all of the needles were, specifically in the craniocaudal dimension. We've also developed a balanced steady-state free precession sequence specifically for optimized visualization of positive contrast markers. And Christine mentioned these in her segment of today's presentation, which can enhance your visualization of where the tip of the interstitial applicator is. They essentially look like tiny fiber optic cables. They're inserted into the interstitial applicator or into the tandem, and they will appear as linear foci of increased signal rather than just the linear low signal you expect to see for the needle on MR imaging. And this can be particularly helpful in needle insertion cases with complex tumor geometry if you're having difficulty seeing where the needle tips are for dosimetric planning purposes. The caveat is that you need a sequence that allows you to visualize the positive contrast markers as areas of positive contrast, otherwise you're getting no benefit from putting those markers in. So we have found benefit in using the balanced steady state free precession sequence. We run this in the axial or sagittal plane depending upon the case and our needs as an optional sequence if markers have been inserted. All of the major clinical MR vendors have a balanced steady state free precession equivalent sequence that you can adapt and run for your protocol purposes. Next slide, please. And these are some examples of what the benefits of these individual sequences are. So this is a different case to the index case that Lilie had presented, but in the upper left, you can see an endocavitary implant, the Tandem and the ovoids, in a patient with a large mid-treatment tumor, despite upfront cisplatin and external beam radiation, extensive posterior parametrial tumor extension. You can see the benefits in the upper left corner of the 2D sagittal T2 weighted acquisition, and in the upper right corner, the 2D axial T2 weighted acquisition, to allow you to see the extent of tumor and also the relationship of the endocavitary implant to disease. You can see in the bottom two images in the lower left of this slide the benefits of these sequences as well for visualizing your interstitial applicators. So in this case, we placed the radiation oncologist placed several needles into the substance of her residual disease, which could also be well visualized as linear foci of low signal, as seen in the lower left panel, or as areas of punctate signal void on the axial T2 weighted images in the lower right. If you look at the right-hand half of the slide, you can see the balanced steady state free precession sequences that we run as an optional sequence in those patients with positive contrast markers. This is now the same patient with those markers inserted, and you can see why we run this sequence when positive contrast markers have been inserted, because in this case, using the balanced steady state free precession sequences, we can now see those markers as areas of increased signal intensity as opposed to low signal. So if you're dealing with complex tumor signal intensity on T2 weighted imaging, multiple needle insertions, and difficulty with visualizing the cranial aspect, the superiormost margin of your needle tips for dosimetric planning purposes, positive contrast markers are an option, and running those in conjunction with a balanced steady state free precession sequence can allow you to visualize them with greater confidence. Next slide, please. So for our imaging acquisition purposes, we utilize a 3 Tesla wide bore magnet. Imaging can also be performed on a 1.5 T magnet, provided you've tested and optimized your protocol for 1.5 Tesla imaging. Our patients are immobilized in the lithotomy position. As was mentioned earlier, because we don't perform these patients in a dedicated OR MR per se, we don't have the routine OR MR transfer table in place, but we have used an MR safe transfer table with stirrups built in to allow for appropriate patient positioning for insertion of the applicators. Scan extents include axial T2 coverage from the perineum to L4-5 and sagittal T2 coverage from acetabulum to acetabulum. When your technologists are mapping out the coverage for a patient with larger extensive disease, you will be able to see on the scanner for that particular patient if individual per sequence time is getting long because of the extent of anatomical coverage. And you always have the option to modify that in real time to make your individual sequences fall within shorter scan durations. You can see here in the images on this slide, the slide in the upper right shows you our sagittal localizer with scan coverage of the axial T2 delimited by the gold lines in subpart A. And in the lower right of the slide, you can see the axial localizer demonstrating the general scan extents we use for our sagittal T2 acquisition from acetabulum to acetabulum. Next slide, please. So as mentioned, we use the MR transfer table with stirrups built in. This is a picture of that table. We use also MR safe or MR conditional brachytherapy applicators, and there are various options that are commercially available. Anything that's stainless steel cannot be assumed to be MR compatible. Primarily what we use for metallic instruments are titanium, as for other intraprocedural MR guided interventions, or plastic applicators or speculally as needed. We went through a process where we essentially overhauled the existing GYN rad-onc inventory to make sure all the components for equipment used essentially from soup to nuts were in fact MR safe or MR conditional. That is highly recommended in time. I would invest up front for safety purposes before you launch a service like this, so you can be assured that all the equipment you're using is in fact safe to bring into the MRI environment. Next slide, please. There are a couple of practical considerations to have to grapple with, though, when you bring all this equipment into the space for near real-time MR-guided GYN brachytherapy implant placement. If you're imaging patients on a transfer table, that will increase the distance between the patient and the patient's anatomy and the in-table RF coils that boost your signal to noise for maximal high-quality resolution. So there will be a relative reduction in signal to noise ratio for your images when a patient's placed on a tabletop that's sitting on top of the MR table. That will require some degree of protocol optimization. It's not unhelpful to partner with your imaging physicists in your department and diagnostic radiologists to help with protocol optimization before proceeding with these types of studies. There is also importance in phantom scanning prior to launching a quote routine protocol for real-time MR-guided GYN brachytherapy implant placement. What's the purpose of phantom scanning? That allows you to verify the fidelity of your hardware, your protocol, your scanning software, and assess the inherent magnetic field homogeneity in that room. There are many things that can perturb that during scanning, and it's best to know about those up front prior to scanning an individual patient. We have some images here on this slide that show examples in the lower left of sagittal acquisition, and in the middle and right of the axial acquisition T1 weighted images of our ACR large phantom, which we use for clinical QA of the MR scanner prior to scanning patients. That allows us to assess SNR and the uniformity of the magnetic field. Next slide. It's also very helpful if you are able to optimize your protocol in volunteers. And this is oftentimes a point that one doesn't really think about, because the goal is to scan patients, and ideally as soon as possible, to be able to offer this type of technology to them. But it is very helpful up front if you can scan a finite number of volunteers to ensure your protocol is optimized for scanning purposes. The optimization really compensates for SNR, allows you to verify what scan time will be in an actual patient, and compensate for any changes in treatment positioning that you think you might anticipate. You're also able to confirm whether the slice thickness prescribed in your protocol is in fact optimal for your needs to visualize adequately the tumor and your hardware, including any slice thickness intervals should you choose to build those in. Most of our sequences for our 3 Tesla protocol that are high resolution sequences are 2 millimeters without a gap. If you're using an older scanner or 1.5T scanner, you may need to adjust that slice thickness, i.e. typically increase it to say 3 millimeters, given you're going to expect a reduction in SNR. And the thicker slices will reduce the relative noise at the lower field strength that you will encounter. Here we have an example of unoptimized versus optimized images that were able to be acquired in a healthy volunteer. In the panels labeled A and B on the left, you can see the axial T2 weighted acquisition and the sagittal T2 weighted acquisition in a patient with multiple uterine leiomyomata. And you can contrast those images to the images on the right, images C and D, where you can see more clearly the normal low signal intensity cervical stroma in subpart C. And in subpart D, you can see more clearly the T2 hypointense uterine leiomyomata that are not as well visualized in subpart B. And we see these types of benefits in patients with in situ tumors as well, thus the benefits for scanning volunteers up front. Next slide. It also allows you, volunteer scanning, to evaluate the in vivo environment and evaluate up front any unforeseen challenges with the equipment you're going to be bringing into the room and the impact that's going to have on your MR image quality. So you're evaluating the patient, the interactions with patient, equipment, and any protocol specific factors cumulatively on your imaging. Here's an example of something we hadn't predicted we'd encounter, but we were able to troubleshoot and resolve with our imaging. In the images on the left, you see this linear band-like artifact going across the entire image, including across the area of the cervix where we'd want high quality imaging. This was in fact due to the presence of MR compatible metallic screws on the sides of our transfer table, which, while MR compatible and able to be brought into the MRI environment, reduced our image quality because they imparted increased magnetic field inhomogeneity. So we removed those screws. We were able to replace those with non-metallic machined replacement parts. And as a result, with the replacement of those screws, we were able to resolve the artifact present on the imaging and subsequently screen and image patients without incident. So it's important to be able to scan in volunteers up front and ensure you're not going to be encountering these types of incidents that when scanning a patient could be more challenging to troubleshoot in real time. Next slide. And then a not insignificant point, in fact, this is vitally important, is to remember your MR safety principles when scanning and performing GYN brachytherapy in the MR suite. This applies to your personnel, patients, and equipment, as ferromagnetic materials may become projectiles near an MR scanner, and these could be subpart components of the actual procedural equipment inventory or something you didn't envision being brought into the vicinity by a member of support staff. So the vigilance of those monitoring the procedure is really of paramount importance. Remember as well that any medical implants may cause heating when exposed to radiofrequency stimulation during MR scanning. Most of your patients will have undergone MR imaging before they come for their implant, so their relative MR safety is not an issue, but always important that they undergo screening with the appropriate questionnaire prior to being brought into the suite. And if there are implants in place, scanning at 1.5 Tesla with monitoring is mandatory. We're also going to hear at this point about additional specifics related to equipment component safety essentials pertinent to GYN brachy by Samantha Simiele.
Thank you. I'm just going to make a couple of quick comments about our applicators. We have developed a very robust process for making sure what we are bringing into this OR suite is safe for both the patient as well as our staff. One of the first things we do before we consider using any type of applicator in the MR space is we review the IFU. And we don't just review this within our team, we also reach out to our collaborators in imaging physics and they review this IFU with us. We are reviewing the stated materials included in the applicator components. We're also looking at what testing the vendor did for this equipment to state that it's MR compatible. We're looking at the magnet strength they performed their testing under, as well as any other conditions stated. If we have any questions, we contact the vendor. Once we're happy with the information in the IFU, we will sterilize our equipment and we individually pack each piece of equipment in a peel pack. One of the reasons we do this is we will take a hand magnet prior to going into any procedure, and we will test each piece of equipment as a sanity check, and we will label each piece as either MR safe, MR conditional, which would be based off of the IFU information, or MR unsafe. On the day of the procedure, we then hand this equipment over to our colleagues in imaging physics, and they do a final scan using a hand wand of each piece of equipment. During the procedure, we have a very systematic process of doing a timeout prior to each scan. We keep track of every piece of equipment going into the OR suite as well as coming out. The only other comment I will make is we individually wrap each piece of equipment because you do not want to scan your equipment or test your equipment for ferromagnetic material while it's assembled. And that's because you could have, say, an obturator that's made of stainless steel placed inside of a titanium needle. And if you were to test for ferromagnetic material, that titanium needle may actually shield the obturator, and you would not know that you have something present that should not be in your MR suite. I'll go ahead and kick it back to you, Dr. Venkatesan.
Sounds good, thank you. So what are some practical image guidance concepts just prior to performing your procedure and on treatment day? Number one is your candidate's eligibility for MRI, as mentioned, with respect to MR safety considerations, also patient size and morphology. We perform these procedures in a 70-centimeter wide bore magnet that has a 500-pound maximum weight capacity on the table. But not all patients who are near that weight limit may in fact fit into your 70-centimeter board. It depends on their body habitus and distribution of fat. So if there are questionable cases, not unhelpful to, in some cases, have the patients have a test run on the MR tabletop. Again, most patients coming to you will already have had an MRI, so you can feel fairly confident you can scan them, but if there are any questions, a test run is not unhelpful. Always review your original and most recent MR studies for the original extent of disease and most recent assessment of disease, and do as much as possible, leverage the benefits of multiparametric MR imaging. Your diffusion-weighted images and dynamic contrast-enhanced images on your pre-treatment images can be very beneficial for looking at original disease extent, as that may inform dose escalation during your implant placement. In the index case that we've presented today, we have her images here, where we can see in the middle two images on this slide, the axial T2 weighted images, and at the bottom, the axial ADC images. On the right-hand aspect of the slide, we can see the image that were obtained just prior to MR-guided brachytherapy, where we still see a sizable tumor, as was mentioned, with extensive mesorectal infiltration, and both abnormalities on T2 weighted imaging and still extensive restricted diffusion throughout the tumor. Next slide. So on treatment day, what are some tips that are beneficial? When using PACS to evaluate your images during the procedure, helpful to use your single-click localizer tools in PACS to quickly see where you are in the sagittal, coronal, and axial planes if you're acquiring all those planes as part of your protocol. You'll want to compare what are the planned dose distributions for your Tandem versus your Tandem plus needles against the volume of gross disease you see on MR to allow you to map out how many needles you want to place through your applicator and which needles in which locations. In this case, our team knew that they were dealing with a patient with eccentric tumor, predominantly to the right, but also left parametrial tumor extension. And therefore, we're going to use needles preponderantly on the right-hand side of the applicator. It's important as well when planning that out to know your hardware and remember, as was mentioned earlier, that the ovoid holes allow for both parallel and oblique needles to reach the parametrium. And typically these are going to be consecutive in alphabetical order. So say needle C will be oblique, but B and D will be parallel to the tandem. Next slide. And you can see then how you can visually map the configuration of the ovoids and the fenestrations for the needles onto your tumor morphology when you plan out which needles you want to use and how many. Next slide. In terms of helpful measurements as well, you'll want to evaluate the distance from the tandem and the endometrial cavity to the lateral margins of gross disease to plan how much radial coverage you're going to need with your interstitial needles and whether you really want to take advantage of those oblique needles that tend to be able to be inserted further out into the parametrium. You'll also want to measure from your vaginal ring to the superior margin of target tumor if you're going to be loading your ovoids with the needles and just not deploying them beyond the edge of the ovoids to plan your subsequent depth of needle insertion once the entire hybrid applicator has been placed into the vagina. And remember, if you have a gap or interslice interval between your individual slices that you acquire, to multiply your slice thickness by the gap, plus or minus the gap, by the number of slices to confirm your total distance that you want to insert needles from caudal to cranial. Remember as well that there is a relative quote unquote dead space between your instrument tip and what will be your distal most source when confirming what's the optimal tip location where you want your needles to end up. So that's 12 millimeters from the tandem tip and 5 millimeters for your interstitial needles. Next slide. And so during the procedure, do you make abundant use of your T2 weighted images, your high resolution T2 weighted images, including, as mentioned, the multiplanar acquisitions that you can acquire as shown on this slide, and while you're adjusting and inserting additional needles if that is deemed beneficial based upon your initial imaging data sets. As with any image-guided brachytherapy procedure, the same challenges will exist with respect to needle insertion. You may encounter resistance due to the presence of a fibrotic tumor or prominent parametrial vessels that you didn't anticipate would be in such close proximity, and serial imaging in this setting can be beneficial. Do remember that in general, MR scan times are going to be longer than CT, and that will be something to pay attention to as you're doing a complex multi-needle insertion procedure. Next slide. And as mentioned, consider not only labeling images external to the patient, but also the actual images in packs. You'll want to label where the needles are on packs if you can, to remain oriented when you put in multiple needles from caudal to cranial. Needles are labeled outside of the patient, but once you place them into the patient and start interpreting your images, it can be a little confusing, especially when you want to make expedient decisions about which needle you're actually dealing with on the images. So we found it beneficial to label those needles in packs on your annotated images and then follow those on subsequent series that you acquire with greater confidence as to which needle is in which location. Next slide. So in terms of putting it all together from the imaging perspective, again, a careful review of your pre-implant images is beneficial to inform you about distribution and where you'd likely place the needles, with that corroborated on treatment day. You want to be familiar with your hardware and the anticipated needles you're going to place and their configuration, whether parallel or oblique, and how many. Measure your distances from the vaginal ring, from the ovoids up to the cranial margin of tumor and out radially from the level of the tandem. And then when acquiring your images, don't be shy about labeling your images as you go so that you know where the needles are in relation to one another. Next slide. And so if we put it all together for the initial patient that we presented, what did things look like at the end of the case? You can go ahead and run the video. We can see here the tandem has been labeled, as well as needles B, C, D, E, and F, which were the ones elected to be used for this predominantly eccentric to the right parametrial tumor extension to boost dose to that area of disease primarily, but also in general to the whole area of disease that remained. These are images taken at the level of the upper vagina. And in a moment, we'll scroll up higher so you can see where the needles ended up and what these look like on MR imaging. Note that as you scroll upward and through the area of the ovoids, the needles become difficult to see, but they can be seen as subtle foci of increased signal relative to the complete void at the level of the ovoids. As you continue to scroll up, you can see what we expect to see for the needle as these linear areas of low signal coming out of the ovoids into the substance of tumor. So in this case, we can see needle C as the first needle that's placed very laterally. In this case, this is one of the oblique needles within the applicator, and you can see its oblique reach as compared to some of the other needles we'll see in a moment, which are more parallel to the tandem. That can be leveraged for eccentric lateral parametrial disease as it was in this case. We can see subsequently as we scroll upward, needle E into the posterior aspect of that right parametrial tumor extent, infiltrating the mesorectum, in this way drawing out and expanding the dose that can cover this tumor that remains large and infiltrative. Here we have the anterior located needle, needle B, that's the anteriormost image in the anteriormost needle in this case, and how it's able to boost dose along the anterolateral aspect of residual disease here, coming up close to prominent parametrial vessels, but not traversing them. And as we continue to scroll upward, you can see needles D and F placed into the posterolateral aspect of this disease on the right again to boost dose and draw the dose outward posterolaterally to the right to treat that residual tumor that remains. As you continue to scroll up, you see at that point, superiorly, what you have left is the tandem, but also with a very small residual of disease superiorly otherwise surrounding that tandem that should be able to be well treated with the tandem itself. And so you can see here the benefits of MR imaging for confirming with confidence before the patient leaves the treatment room what the distribution of needles are within the substance of tumor. Next slide. And we can play this as well. If you choose to get a coronally reformatted image, you have that benefit as well. What's the benefit primarily of your coronals? You may always be wondering what's the superiormost aspect of these needles? Where exactly are they located in craniocaudal diameter? And this will allow you to see that with confidence. So in this same patient's case, we can see the coronal T2 FRFSE images in this case, scrolling from anterior to posterior. So from the level of the urinary bladder with the Foley in situ, we scroll posteriorly through her tumor.
Wonderful. Thank you so much. Those images are really telling. I always think too, the more images we get, the more I worry about some of the structures like the ureter and the vessels. You can see how close they are in some of these implants. So while we get ready to transition to talk a little bit about planning, would you just comment on the best way to visualize the ureter and parametrial vessels on the images that we are using, the sequences we're using for brachy planning?
So in general, we rely on our 2D T2 weighted acquisitions to see your ureter well, and also to see parametrial vessels, simply because their in-plane resolution tends to be higher than your 3D acquisition. And when looking for ureter, you have the benefits of the increased T2 signal if the ureter is dilated to leverage as well to find its location. When it's not dilated, we always rely on not just the 2D T2 weighted acquisition, but also scrolling reliably through your images so that you can follow what should be a tubular structure from the lower pelvis to the level of the UVJ.
Wonderful. Thank you so much. So we have just a few more minutes, but I want to make sure we hit some of the planning guidelines that are important, Christine, and then we'll show at least one of the, well, hopefully we can show 2 implant plans and what the use of hybrid applicators were able to provide.
So like it was mentioned, we can either do based on where we've done our implant, whether it be the MR suite or the CT brachy suite. We do have options as far as placing dummy markers for a CT scan to help ensure accuracy for the digitization of the applicator needles. Or, as mentioned, we have positive contrast markers that are filled with C4 material so that we can see the lumen on an MRI scan. So either of those are, we place those prior to the final scan. Once we get that final scan, our workflow would be to, again, digitize the applicators as accurate as possible. Then we would activate the dwell positions that would most benefit our dose distribution. We would place our A points and our vaginal surface points. Then moving into optimization, we would normalize to those point A's and then manually change the times to gain coverage or spare OAR doses. So you can do the next slide. So moving into tandem activation, here at the crosshair would be the top of the lunar ovoid cap. So when we activate our dwell positions, each dwell position is going to be at 5 millimeters. And two, we don't want to activate closer than 3 to 5 millimeters from the top of that lunar ovoid. We know that the offset at the tip of the tandem is 12 millimeters. Keeping in mind earlier, whenever I had put the system together, sometime we'll also lose, as you're hooking in the tandem to the ovoids, you're also going to lose about 6 millimeters distance as well as the tandem pulls back in the uterus. So just keeping in mind when you're choosing your tandem lengths. I think the longest length we have is 7 cm. So with that, you would only have about 5.8 millimeters of active length. With your tandem, go to the next slide, please. So for needle activation, same thought process. You don't want to activate a source in the needle more than 3 to 5 millimeters from a source in the lunar ovoid. We use the 6 French 294 millimeter needles. So the offset for those needles is 5 millimeters from the tip of the needle. And the indexer length for these are 1294 millimeters. And we use a micro selectron. So the indexer length for the tandem and the lunar ovoids are both 1500 millimeters. Next slide. So here it shows some options as far as activating dwells in your lunar ovoids. We standardly load 4 in the lateral aspects of the ovoid cap, but we do have that option depending if they have anterior disease or posterior disease or just have a larger cervix. If you want to activate the 5th dwell position, that's also an option. And the offset in the lunar ovoids is 6 millimeters from the posterior edge of the cap. So moving into manual HDR planning and optimization. So once you've placed your A points, you're going to use the optimizer in the treatment planning system to normalize to those points. The optimizer will give each catheter a weighting of 1. So once you have that, we found that a weighting, we found that a weighting of 0.67 is a good starting point when optimizing in the tandem, especially depending on the number of needles that you're going to be using and how much gross disease the patient has. But again, these are all starting points and you can manually adjust as needed. So manually decreasing the dwell times in the tandem by 10 to 20% is also another way that you can kind of have a starting point, again, depending on the number of needles. So 1, you start with that weighting of 1, and then you decrease to the 0.67. And if you need to decrease at 10 to 20% increments, that's fine as well. So moving into the next slide. So here's the optimization of the lunar ovoids. So we know that the edge of the ovoid cap from the center of the source train is 7 millimeters. So we usually, again, if you have 4 dwell positions, the center of the source would be between dwells 2 and 3. If you use 5, it would be dwell position 3. And you just take a lateral measurement from the center of that source out to 7 millimeters. And we're going to be tracking dose to that area. you can move to the next. So here's a picture of just the Tandem and the Lunar Ovoids with no needles activated. And you can see in the image at the top, that's the axial image with at the level of the A points. And at the bottom is a coronal image showing the lateral extent of the HRCTV. So moving into the needle optimization. So earlier I talked about keeping 3, which is our Tandem, at around a 0.67 weighting. So catheter 4 in this case is going to be one of the needles. As a starting point, we always take 10% of the time of the Tandem. So the time here is 13.75. And then I input into the needles 10% of that, which is 1.38. And again, this is just a starting point. I would add that time into every single needle and then look at the dose distribution and the OARs, and you can increase or decrease to gain coverage. As far as lunar ovoid optimization, I think I skipped over that earlier. So what we would do is manually reduce the dwell times, ensuring the surface dose does not exceed 120%. We know that once the needles are activated, this will increase the overall surface dose to the acceptable limits of 130 to 150%. Remembering that the distance from the source to the surface of that lunar ovoid cap is rather short, it's only 7 millimeters. Again, another tool within OnCentra is using the dwell position selector. So again, as you can see out laterally, you can choose which dwell positions you need to obtain coverage and then manually increase those dwell times. And again, remembering each dwell position is 5 millimeters apart. So it's beneficial as you're optimizing to choose at least 2 dwell positions so that you can either spare the organ at risk or increase the dose to that area. In this picture, this is our optimized plan now. It's the same plan as before, but with the needles activated. So you can see we were able to obtain that coverage out laterally, also while sparing that sigmoid that's there on the patient's left side. That's rather close to our A points that we would be tracking dose. And so our goals for using the hybrid applicators is in patients with bulky disease, so the width, the length, and the height, and large cervical tissue, such as 3.5 to 4 cm cervix. We found that using bilateral parallel needles significantly reduces the OAR doses in the bladder, rectum, and sigmoid while not sacrificing coverage to our HRCTV. So here are some dose considerations for each HRCTV and all the OARs, as well as the vaginal surface dose and point A. So in the first column, this is percentage dose per fraction. And then the next column is what we use clinically here at MD Anderson. And then the next 2 columns are the soft and the hard embrace guidelines. So here in the clinic, we use our dose limits are similar to what Embrace is published. Next slide.
All right, so I'm going to take over here and review the plans for the patients that Dr. Lin introduced earlier. As a quick side note, some of our patients here are treated with PDR and some are treated with HDR. The 2 patient plans we'll be reviewing were both treated PDR. So we'll start with the first patient. What you're seeing on the screen are the 3D renderings from our treatment planning system of our implants. At the top of the slide is the renderings for our first fraction. This was treated intracavitary with Tandem and ovoid, 45-degree Tandem, 15-degree small ovoids. We loaded 12 dwells in the Tandem and 3 in each ovoid. At the bottom of the screen is the 3D rendering of our hybrid applicator implant. This was accomplished using the Venezia with needles. We implanted 5 needles. 2 were oblique, the other 3 were straight. You can see the number of dwells loaded here on the left. What I would like to point out quickly is there were two real benefits of moving to this hybrid implant for this patient. The first was the posterior coverage we were able to achieve using the needles, both the straight and angled. And the second was we were able to better cover the lateral extent of the disease on the patient's right side. We do have some quick screenshots here for you, moving from the axial through the coronal down to the sagittal as you move down the screen. The left side is her first fraction, that's the intracavitary, the TNO, and the right side is our hybrid implant. Our axial cut here is through the ovoids, and then on the right side, it's through the lunar ovoids. The main thing I'd like to point out, the red isodose line is our prescription isodose line, and you can see that in our intracavitary implant, we did have suboptimal coverage of our high-risk CTV, whereas with the hybrid applicator, we were able to better conform the dose. This was primarily accomplished using the angled needles. The same can be said for the posterior extent of the disease. You can see that we do have better dose conformity using the hybrid implant. So I'd now like to step through the doses we were able to accomplish, both with the intracavitary implant as well as with the hybrid. A quick note, because these patients were treated with PDR, they were treated with 2 fractions, not the traditional 4 to 6 you would have with HDR. So what you're looking at here is our target structure as well as our relevant OARs for this case. Because we're treating with PDR, we are treating in pulses, and we typically treat with 44 pulses per fraction. So the dose purported here is in centigrade, not gray. And if you take this per pulse dose, multiply it by your 44 pulses, you arrive at our per fraction dose. We make an assumption at the time of our first implant that the first implant dose will be equal to the second implant dose. And we make that assumption so that we can estimate a cumulative dose for the entire treatment, including external beam. Again, it's an assumption, but this does give us an idea of where we're at with this first plant and what we need to accomplish with our second implant. So if we double these per fraction doses for this assumption, and then we add in our external beam dose, this is taken from the patient's external beam treatment plan, we can arrive at our total estimated dose. If we then compare that with our Embrace guidelines, we have both the soft as well as the hard guidelines shown here. We can see if we were to treat this patient using an intracavitary implant twice, not using our hybrid applicator, we would not be achieving the coverage that we were hoping for. We would not meet our hard dose constraint. We would be meeting our soft dose constraint for the bladder, but just barely. The same can be said for the rectum. And for the sigmoid, we are just barely meeting our hard dose constraint of being less than 75 gray. So let's now take a look at what we achieved clinically using a combination of the first implant for intracavitary and the second implant using the interstitial hybrid case. So again, we have our doses from our first fraction treated clinically. These were the per pulse and per fraction doses for our hybrid implant. We can then add in our external beam dose to arrive at our total doses for this patient's treatment. Again, comparing to Embrace, we can see that using this hybrid applicator, we were able to achieve our hard dose constraint. We were at about 87.5 gray compared to the initial 82.8 gray. Our bladder dose did increase slightly using this hybrid applicator. We were just under 82 gray. This did meet our hard dose constraint. Previously, if we had just treated using intracavitary, we would have met our soft dose constraint. The same can be said for the rectum. We once again met our hard dose constraint. Previously, we were meeting the soft dose constraint. And an important point here is that our sigmoid dose remained unchanged. We were once again still just meeting the hard dose constraint. If we calculate the difference between the total dose for each of these structures between what we treated clinically versus what we would have estimated using only intracavitary treatments, we can see that we were able to escalate our high-risk CTV coverage by almost 5 gray. Our bladder dose did increase slightly to 2.6 additional gray, and the rectal dose did increase to approximately 5.4 additional gray. Again, the sigmoid remained unchanged. What this case really demonstrated was that we can achieve dose escalation to our high-risk CTV that could not be achieved using intracavitary alone. Do we have time for a second case?
Yeah, let's wrap up with this last case.
All right, we're going to step through this the same way we just stepped through the first case. Again, this is also PDR, so 2 fractions. Again, you're seeing the 3D renderings on the screen here. The first fraction is on the top, the second fraction is on the bottom. This first fraction was once again intracavitary. It was treated 45-degree tandem, 30-degree small ovoids. The second fraction was our hybrid. It was treated with 4 needles. We did not use oblique needles in this case. We used 4 straight needles. Just from the 3D renderings, we can see the improvement in our coverage posteriorly. Again, we have our cuts through the axial, coronal, as well as sagittal views. The main improvement you can see is the stretching of our prescription isodose line to cover the posterior extent of our target. So this case actually demonstrates something a little different about what we can accomplish with our hybrid applicators. I'm going to step through this the same way I stepped through the first one. If we start with our first fraction treated with just the TNO, we have our per pulse doses as well as the per fraction, assuming 44 pulses were delivered. And for our estimate following the first fraction, we're going to assume the same dose was delivered for the first and second fractions. We add in that external beam dose, we can arrive at our estimated total. If we compare this with our embrace guidelines, we can see that our target coverage is quite good. We are meeting our soft dose constraint. Our bladder dose is meeting our hard dose constraint. The rectum is meeting the soft dose constraint. And the sigmoid is slightly over our hard dose constraint. So one of the things we hope to accomplish using this hybrid applicator was to decrease our OAR doses. Our target coverage was excellent. We were concerned about our OARs. So let's look at what we achieved clinically. Again, we have our first fraction dose results. These were the per pulse doses and per fraction dose for the hybrid applicator. Again, we have our external beam. If we sum the 2 fractions plus the external beam, we arrive at our total doses. And what we can see is with using the hybrid, we are still meeting our soft dose constraint. We expected that to stay approximately the same. The other thing you'll notice is that our bladder dose has decreased from our original estimate. We are now meeting our soft dose constraint, whereas previously we were only meeting the hard dose constraint. For the rectum, once again, we're meeting the soft dose constraint. And then for the sigmoid, we are now meeting this hard dose constraint that we were previously just over. If again, we take the difference between our total doses for what we delivered clinically and subtract our estimated dose if we had just treated with 2 intracavitary implants, we can see, as I mentioned before, that our high-risk CTV dose has remained somewhat unchanged. It's less than a gray different. However, our bladder dose has now decreased by 6.5 gray. The rectum and sigmoid doses have now decreased just slightly over 1 gray. So what this case has demonstrated is that using this hybrid applicator, we were really able to accomplish a dose reduction to our OARs while maintaining our target coverage.
That's great.
So those are the 2 plans. Back to you, Dr.
Finish up.
Nope, that was it. Back to you.
Wonderful. Yeah, I think these 2 cases are a great illustration. And the other case that we had was a HDR case, but the principle is the same, is that when we look at our projections based on the intracavitary implant, if we're not happy with what we're achieving, we found that hybrids help us achieve those embrace goals. So with that, we've run over time. I really appreciate everybody joining and you all for making time for the presentations. We've had some great questions in the chat, which we've tried to answer as many as we could. I know we're all happy to help with people walking the same road, so please reach out if people have questions that we can help with. Much thanks to Elekta for support with the applicators and support for the webinar. and hope to get more opportunities to talk about this in the future. So thanks, everybody. Goodbye.